You guys can see this, my screen with the
We can see it.
presentation.
It's not in presentation mode.
Yes, that's fine. Yeah, this is one that I don't. It's my computer at home. That's why versus like a school computer. Older version of PowerPoint here. All right, so let's get this into presentation. There we go. Perfect. Okay. All right. It's been a while, sadly, since I've been able to be on Zoom because they make us use Teams over with me. Let's see. How do I get rid of? There we go. Okay. So this is me with my family. So with my husband, Steve, my 5-year-old daughter, Violet, and my son, Wyatt. So I'll talk to you guys about the journey I definitely had to get these two in my life as we kind of go along. So Dr. Hall said that you guys already kind of talked about endometriosis, but I feel like I needed to kind of define it again. So endometriosis is a condition where the tissue similar to the uterine lining grows outside of the uterus. And you can kind of say that word, but what a lot of people don't realize is that outside of the uterus means literally outside of the uterus. So a lot of people think of endometriosis as, outside of the uterus, meaning it could be like next to it or whatever. No, I'll kind of talk about soon about how it can go literally anywhere in your body. I have had people that I've talked to that have endometriosis that have had it go places to their colon, their bowels, their heart, and even the brain. So endometriosis can literally spread anywhere. So for symptoms, there's chronic pelvic pain, painful periods, pain during or after sexual intercourse, fatigue or low energy. You can also get pain with urination or bowel movements during your menstrual period, but honestly, this can happen even after your menstrual period, depending on where it has migrated to. You can also get heavy bleeding during your periods or spotting between periods and stomach pain like diarrhea, constipation, or bloating. So any one of these things, but honestly, those are just the common symptoms. Again, depending on where the endometriosis is found, you can actually have worse symptoms than that. So for treatment, doctors love to just say, take a nonsteroidal anti-inflammatory drug like ibuprofen. The next thing that they like to kind of peddle out is birth control pills or other contraceptives. And I'll talk about why it's really important what type of birth control pill is taken, as well as why this is a Band-Aid, not a solution. So although it says treatment, those two things, the anti-inflammatory drugs and the birth control pills, are not going to treat the endometriosis. It will not get rid of the endometriosis. You can, though, have surgery to remove gross and scar tissue to try and remove the endometriosis that is found. Endometriosis is often undiagnosed or misdiagnosed for years. And when I say years, in my case, it was undiagnosed or misdiagnosed for almost 20 years. So it is not unusual for a woman to not have a doctor tell them that that's what they have, and one of the reasons is not only because are they not, believed, but also because getting a definitive diagnosis requires surgery. So as of right now, there is no way that is non-invasive or that doesn't involve surgery to diagnose endometriosis. The true way to get diagnosed is for somebody to go in there, do surgery, and see, oh, look, this person has endometriosis. So you can't get any scans, nothing like that done to truly diagnose this. In a lot of rare cases, these surgeries can cause very significant complications. I'm one of the lucky ones that it didn't cause complications for me, but being in support groups and stuff like that, I promise you, it's not as rare as you would think that they would cause complications. Okay, so into my story. So in 1999, my journey first began, like most women, with very abnormally painful periods at the age of 13. So almost as soon as I started my menstrual cycle, it was very painful. I went to my doctors, I went to my GYN, and basically was told it's normal. It's completely normal to have this intense of cramping. It was to the point where at 13 years old, I couldn't go to school. on the day after I started my menstrual cycle, it didn't seem normal to me. But this is what I was told. I was basically told, go home, take some ibuprofen. And at 13 years old, I was put on birth control. I was not sexually active, but that was the only treatment that they were currently giving out for the from the OBGYN. No other treatments I was told were available or honestly were told to me. So at this point, this is all that I was told. I took these and it brought it down to a manageable level at this age. But the problem is going on birth control at that age, it meant that I ended up going on hormones for years, decades almost. Lucky for me, at the time when it was diagnosed, my birth control had a very small copay. And eventually after, oh man, I think it was when Obama was in office, eventually most birth control types, especially of the pill variety, became free. So I eventually had no copay. The only thing that I was really paying for was the ibuprofen that I was purchasing. At that time, though, I was told not able to get a true diagnosis. I wasn't believed, or I didn't know for over a decade that I even had endometriosis. I just knew that I had painful periods. Nobody told me this thing about endometriosis even existed, let alone even tried to run tests to say that that's what I had. Then I got to run into the multiple things that were told to me by a GYN during uncomfortable exams. I had multiple GYNs throughout the time because of different reasons. Like I started at one and then that, office closed, or I moved to college and I had to get one close to college, used a different one in grad school. And each and every single one of them just kept brushing me off and telling me again, it was normal. One worse one definitely was, I was about 19 and I, at that point, had experienced multiple uncomfortable exams and pelvic exams. And what I was basically told was by that man, it was very uncomfortable for me for them to use the speculum, anything like that. And this male GYN told me, don't worry, once you have more partners, it won't be uncomfortable anymore. So that not great. Definitely uncool that it was that was told to me. I was not, and sadly that wasn't the last time that I was told something along those lines, that it would get more comfortable as I had more partners. P.S. that's not true. So that's kind of how it started. And then we started to progress as the years went on. So then in 2006, 2018, I continued to have very painful, uncomfortable symptoms. So you can see here, I kind of do a thing here. It's got, the heavy painful periods, the back pain during intercourse, fatigue, all of these things, leg pains, all of these things started to happen to me. So despite it being 7 years since I started on birth control, there was still no true diagnosis, despite going to multiple GYNs. And finally, after doing my own research, not told by professors or by GYNs, none of that, I had to do my own research and find out that there was this thing called endometriosis. This is not unusual. A lot of women have to kind of just figure it out for themselves. Honestly, I think with a lot of women's health, and advocate for themselves. So little did I know at that time, though, the endometriosis was growing. Birth control can slow down the growth, but it doesn't stop it. If anything, sometimes it makes it worse because it disguises the symptoms and you think it can't be getting worse. The periods were staying at a fine level. All of these things were starting to appear, but I still managed to go to college. I still managed to get jobs. I still managed to do all these things. It was disguising the symptoms to the point where I just started ignoring it. I just started saying, this is just my life and we should keep going. But again, the key thing here is I was still on birth control. And at that time, I was on estrogen-based birth control. Again, this thing will become very clear soon as to why that was super, super important, that it was estrogen-based. So in 2018, I married my husband, Steve. He was very understanding of the issues that I was having, the fact that I could have days, during every month where I was tired, where I was in pain, having all these issues. But He was amazing. And we decided that year that we wanted to try to start to conceive our first child. And I went off birth control for the first time in 20 years. The amount of pain that I was in was, to be honest, indescribable. It made it to the point where if I knew that it was coming, and lucky for me, I was one of the few that had still very normal timed periods, I knew that I was teaching at the time. So I knew that I would have to maybe cancel class that day, and I would put buffers in to make sure that this could still happen. But it got to the point where I would be debilitated 1, 2 times a month, every single month. And all of the rest of the symptoms got worse. I got to the point where if I ate any kind of food, healthy, not healthy, I felt sick afterwards. I did not realize that was connected to my endometriosis until later, but yes. So then it took us 10 months of trying to have our daughter. During that time, we had 1 miscarriage as well as 1 chemical pregnancy. About 6 months into trying, we decided to go to a very, very popular fertility clinic around here called Shady Grove. And I was told after having 2, maybe 3 very basic diagnostic tests that I don't have endometriosis because I'm not in enough pain. If I had endometriosis, I wouldn't be able to do all the things that I can do. And then the fertility specialist literally said, go home, have sex with my husband. It will just happen. So again, no treatments, no nothing, brushed off. This is a theme. This is a theme, I think a lot of times, especially of the older generation of these doctors, they're not even taught about endometriosis, let alone what to do with them. But it surprised me to hear that from a fertility specialist, especially a fertility specialist of such a large company, where I could not even be close to the first person they saw that had infertility through endometriosis. We decided to just try our own. And I had done my own research showing that sometimes women with endometriosis, their ovulation can be off timing. And we were following an app for ovulation. So I decided to start using ovulation sticks. And luckily, after trying that for a few months, I did get pregnant with my daughter. In 2019, I delivered my daughter, Violet, as you can see here. But unfortunately, the endometriosis issues did not end there. During my pregnancy, it was extremely, extremely painful, debilitating pain, especially in the first trimester. I would come home from work, from teaching, and not being able to told a soul that I was pregnant, because unfortunately I was interviewing for my job at that time, and I was worried that they would not give me the job knowing that I was pregnant. And I would come home and cry. It literally felt like sharp knives, hundreds of them, were stabbing me in my uterus. I now know, years later, not even from my OB at that time, that was because of my endometriosis. Women with endometriosis in the first trimester, due to the fact that that's when your uterus is starting to have things attached to it, starting to grow, starting to make room, and are producing specific hormones, it can flare up your endometriosis to the point of extreme pain. Almost every woman who has endometriosis has very painful pregnancies, especially as they get farther into the stages of endometriosis. But yet again, I tell my OB about this pain during my first trimester, brushed it off by OB. It's completely normal. It's just ligament pain. That's what I was told. It's just growth that's happening to your body. Wrong. It's very important to know at this point that after I gave birth to my daughter, I was put on progesterone-based birth control instead of estrogen-based. I finally was believed after my OB saw that I, was a little off during my C-section of delivering my daughter, that maybe I do have endometriosis. Again, still no diagnoses. If you had looked in my chart, I still was not diagnosed with endometriosis at that point, but it was finally had been shown in those years that progesterone-based birth control is helpful for people that have endometriosis, where it helps with the symptoms a little bit more. The reason why that is because it has finally been shown that estrogen feeds endometriosis. So if you have extra estrogen of any kind, either from your birth control, pregnancy, infertility treatments, which I'll have fun explaining soon why that affected me, all of these things can make your endometriosis grow, and you can end up increasing the stage that you're at. I'm not sure how much, if you guys went into the stages for endometriosis, but they do classify from 1 to about 4/5. It's very similar to cancer in the sense that the endometriosis is defined by how far it has spread. So those with stage 1, stage 2 will have very little bits of endometriosis most of the time around or inside of their uterus. Once you get to stages 2/3 and above, it has started to grow and maybe has started to spread. So that the point that the person who has stage 4/stage 5 has endometriosis that has spread to many parts of their body at that point. But the progesterone-based birth control has been shown to at least not feed the endometriosis. But again, still not a treatment. I still have not been treated for my endometriosis at this point and barely will have doctors talk to me about it. In 2021, we decided to start trying to conceive our second child. We knew that this was going to be tough because it took us so long to have our first, but we knew that we wanted a second child to complete our family. We had always dreamed of having 2 kids. And so we started to try. So we tried for over 6 months to conceive naturally. We tried the ovulation sticks again and again, but this time it didn't work. I had 1 miscarriage again, and again, 1 chemical pregnancy. I had a very hard time staying pregnant. That was the key for me. It wasn't even necessarily getting pregnant. It was staying pregnant.
Yeah. Sorry.
So at that point, coming off the birth control again meant, again, the extremely painful periods. At that point now, it wasn't just I couldn't get out of bed one day right after my period. Instead, it was I couldn't get out of bed multiple days. I had to cancel class multiple times, had to cancel, things with friends. I barely could get out of bed most of the time, the 3 or 4 days worth of my menstrual cycle. It was debilitating. So we decided again to see a fertility doctor. This time we knew to avoid Shady Grove. And we went to a fertility doctor that was recommended to me by multiple friends. These are friends of mine that had babies with this man through IVF. He was a smaller clinic. He's bigger now. It's the, oh my gosh, what is his clinic called now? The Delaware Institute for Reproductive Medicine. He's up in Wilmington, Delaware. But at that time, it was just him. So I didn't feel like I was a number. I felt like he would listen to me, and he did. Now 2021. So this is, 22 years after getting painful periods, I finally had a person believe me. He believed me. He wrote it in my chart that he believed I also had endometriosis and this could explain our infertility. So after multiple tests, it was found that one of my fallopian tubes was blocked. So you can kind of see that here. Blocked fallopian tubes are tubal occlusions. You can see it here. It's kind of blocked here. It actually accounts for about 20 to 30% of all female infertility. And for me, it could be that my endometriosis was causing it. So if my endometriosis had grown out to my fallopian tubes, maybe wrapped around it, inside of it, I could have that blockage. So he decided that he was going to do surgery to clear out that blockage. I see the chats and I will answer them in 2 seconds, I promise. So after he had that surgery to clear the blockage, and again, this man had done it. I think he had been doing this for about 30 years. And he told my husband, this surgery will take 20, 30 minutes. I'll be out. I'll tell you what's going wrong. My husband said he came out 2 hours later. He was beyond surprised how much endometriosis he found in there. He had diagnosed me finally with stage 2, 3 endometriosis. Again, 22 years after going to a GYN, now it is finally written down that I have my diagnosis. He cleaned out the blockage that was from my endometriosis spreading to my fallopian tubes and could, in theory, be the cause of our infertility. And we knew we could then move on. Okay. A chemical pregnancy. Sure. Yes. So a lot of people don't realize that chemical pregnancies and miscarriages are 2 semi-different things in a sense. Okay. So a chemical pregnancy is defined technically as like an early miscarriage. It's a loss that happens before the 5th week. So you would call it like an earlier miscarriage. But the difference is that you test positive for a pregnancy test only to get a negative result a few weeks later. And the signal is more of a chemical. So what it means is that I probably didn't get implantation correctly. Instead, my body was starting to produce the hormones because it wanted to implant, but the implantation never fully happened. A full miscarriage is when implantation happens and then the person ends up miscarrying it. But a chemical pregnancy is more so the body wants it to stick. It doesn't quite stick, but you still start to produce the chemicals that you get a positive pregnancy test. So a lot of times that can be diagnosed with like the timing of it. If you get a positive pregnancy test and then get a negative pregnancy test, not even like a week later, a lot of times it's a chemical pregnancy versus if you test positive and then, like 3 or 4 weeks later, going into what's close to your 8th month or 8th week, and you go into the OB and they say that the baby's not there anymore, that was more likely to be a miscarriage. So it's hard to diagnose both. But with endometriosis, you are more likely to get the chemical pregnancies because a lot of times what happens is the embryo cannot stick to the uterus. The endometriosis has deteriorated the uterus too much that stickiness that the embryo needs is not possible. And I'll talk about that when I talk about the infertility diagnoses and the things that I've done. So miscarriage that happens generally before 5 weeks. Thanks, Amy. Thought I'd just give a little bit more details. Okay, so we cleared everything out. The doctors made me wait a month, said, okay, let's let your inflammation go down. Let's everything chill out. Let's try an IUI. So there are several different levels of what you can try for infertility. The first level is actually even more simpler than this, and this is going on what's called Clomid, which I'll actually talk about Clomid when I talk about IUIs. But what Clomid does is it ends up making it so that you end up producing, okay, I'm going to say this wrong, so maybe Dr. Hall should say it instead. Can you define exactly what Clomid does? Because I looked it up and I got myself even confused. Yeah, see, hold on. I have my notes. Hold on.
So I don't know that we need to go into detail on that, but it helps induce ovulation.
That's what I thought. Okay.
Yeah.
Cool. That's all I'm going to say because that I knew.
Yeah.
So you can have Clomid and you just take the Clomid and it helps you so that way you know the timing of your ovulation, and then you can then monitor that ovulation, and then you just have natural intercourse. So that's like the first step. But we kind of knew that wasn't happening for us. So we decided to try the IUI instead. So an IUI is a procedure that involves placing a very concentrated semen sample into the uterus during ovulation. So you can kind of see this here. They end up putting the sample directly into my uterus. So what this is this is kind of bypassing bypassing my maybe wounded areas, that I might have from endometriosis. And it makes it so the sperm doesn't have to do as my OB or as my fertility specialist said, doesn't have to do as much work. So it's kind of good. The sperm is prepared beforehand. So the sperm, in my case, my husband gave a sperm donor and they sort it for the healthiest. So they sort out any sperm that are dead. They sort out any sperms that have any, issues with swimming, anything like that. And they're able to concentrate it. The sperm is then inserted into the womb through the cervix, but you time it with your ovulation. So we do ovulation monitoring first, and it's monitored through like blood tests, ultrasounds, home ovulation kits, whatever, so that we get it timed as perfectly as possible. Then they prepare the sperm, getting rid of those unhealthy non-motile sperms. Then a thin catheter, which you can see here, is then inserted through the cervix into the uterus, and the prepared sperm is then injected. And then the woman just goes home to rest and hope that the sperm finds their eggs and all works out. So we decided to try that IUI because we weren't quite ready to do IVF yet, knowing that IVF is a bit more extreme. So the medications given during an IUI. So again, Clomid or other aromatase inhibitors like letrozole can be given. They're both given orally, and they're both taken about once a day for 5 days. Both of these, so I ended up taking Clomid. These were covered by my insurance, and I could get them through just a regular CVS with a very low copay. Felt no effects from these medications. It was pretty mild. This was pretty mild. Your doctor begins watching for signs of ovulations to know when to schedule your IUI. Once you begin that, what you can then end up using, you can use human chronic. Nope. You guys are going to be like, HCG is what we all just called it. It's a trigger. So it triggers your ovulation. So if you want to get it timed even more perfectly, you can take this to trigger the ovulation. And then you know that your IUI will then occur 24 to 36 hours later. So that's what a lot of us tend to do if our ovulation isn't perfect, like mine was. So here's the first time that it became a huge pain. So you have to get HCG through a specialty pharmacy. So for me at the time, it was Walmart specialty pharmacy. When I say that this was a big pain, it was a big pain. So you had to go back and forth multiple times. So I had to make sure that my insurance was going to cover it through my specialty pharmacy. Then the specialty pharmacy had to make sure they even had the HCG. And that they had the type that my doctor wanted. I had to go back and forth for about a 2-week period because either the insurance wouldn't cover the original one, so the doctor had to change it. Then the specialty pharmacy told me they didn't have that type. The doctor had to change it, but had to make sure that the insurance would cover it. It was very stressful because everything had to be perfectly timed. The ACG had to be sent and given to me by a very specific time so I could trigger when it was needed. Eventually this was covered, and surprisingly with a very low copay, but having to go through your insurance and going through the specialty pharmacy was incredibly painful. And it's not unusual. Everybody that I talk to that is lucky enough to have this covered, I will say that a lot of people cannot get this covered by their insurance. This is considered to be a Clomid. You can get it covered a lot of times because you can let it fall underneath different things. But HCG, that is a fertility drug. That's what it's classified by. And a lot of times insurance will not pay for that if they're not paying for any fertility treatments whatsoever. So you're paying for that out of pocket. Again, I was very lucky. I had an insurance that would pay for that. But again, you can't get these at regular pharmacies. It has to be at a specialty pharmacy. So we tried 3 IUIs. So 1 month followed by the second month, followed by the third month. And unfortunately for us, all 3 failed. The last one, unfortunately, involved a very late miscarriage. So for me, that was at 4 months. So this was not my usual miscarriages as I had had. My other miscarriages were happening at, the early 5 weeks with the chemical, 2 week. But this one was at 4 months. It was heartbreaking to say the least. We had plans. We hadn't told people besides our family, but I was broken, to be honest with you, after trying for so many times. But after months of thought, healing, talking to therapists, talking to each other with my husband, we called our insurance to see about IVF and how much of it was going to be covered. Ours covered 80%. I will tell you that's one of the best you're ever going to hear. Very rarely does an insurance cover 100%. 80% seems to be the best. To be honest, most of the time it's way less than that. And so we decided that we would try IVF. Most insurances, though, make you do IUIs before they will even cover an IVF. They make you, even if your doctor says there's absolutely no way an IUI will work, no way, it will never work for X, Y, and Z reasons. Insurances don't care. They're going to make you try and fail 3 times most of the time before they will even cover the IVF. And mine was one of those. Again, ours covered 80%, but just because of my heart, I said to my husband, I would try 1 egg retrieval and 1 transfer. Even despite all of that, it still cost us $10,000 out of pocket to do our IVF, egg retrieval, and transfer. Many of my friends I made during my infertility journey were not so lucky. My friend, for example, who did IVF 3 times, had to be completely out of pocket the entire time. They ended up spending, I think, almost $150,000 to now have their 2 children. I will note, he has federal government insurance. Federal government insurance loves to not cover fertility. At least at that time, I believe it's changed a tiny bit since they've done that, and maybe it covers a little. I'm not 100% sure on that one. I haven't looked, but at that time, none of it was covered, which absolutely blew my mind. But they paid for $150,000. Some packages that you buy through any fertility place, you actually buy it as a package, and they tell you that you can keep trying until you have 1 live birth, is what they say. Some say you can have X amount of egg retrievals and X amount of transfers. It just depends on what package you buy. Most people have to fight tooth and nail with their insurance to get them to cover anything or parts. Some insurances will cover the egg retrieval procedure, but not the meds, or they'll cover the meds without the actual procedure, or they'll cover parts of a procedure, but not other parts, which is how mine was. And then there's issues with the billing departments at the fertility clinics. They're frustrated. They're frustrated with the insurance. They're frustrated with everything. It's a constant back and forth. But we did eventually attempt our IVF. So the first thing that you do is an IVF egg retrieval. So with the egg retrieval, you end up first stimulating. So the ovaries are stimulated with hormones to produce multiple eggs. So now it's not Clomid where you're trying to produce just one, maybe two, multiples. You are trying to produce more than your usual one. You then monitor using ultrasound scans and blood tests to monitor the growth of the eggs. So to see how many eggs there are, do they look like they're about mature? Once you get to the point in your blood work where it feels like it's about ready, you do a trigger shot. So you do that hormone injection to trigger the final maturation of the eggs. You then do a retrieval. It's performed under twilight sedation in an outpatient setting. So they just go up, a needle passes through the vaginal wall and into the follicles to retrieve all of the eggs through an ultrasound guide. And then you aspirate and the eggs and the surrounding fluid are extracted into a syringe and eventually taken to a lab where they will then be cultured. So for medications, it's a lot. So first you need the ovarian stimulation ones. These are things like Gonal F, Follistim, Menopur, or HMG. These are always used as part of the protocol. They're kind of like the backbone of it. They choose the dose and they factor in the patient's diagnosis. So for me, because I had such a hard time with my egg retrievals, all this kind of stuff, and it seemed like I had a heart and I was older, I was actually on 3 out of 4 of those all at the same time to just try and produce the eggs. You then have to go on certain medications to prevent ovulation because you don't want to go through ovulation releasing all those eggs before the egg retrieval. When follicles mature, they eventually want to signal the brain to release the eggs. So you can go on 2 different types. You can either have an antagonist or an agonist. Honestly, it just depends on what works within your system and what type of protocol you're doing. I use the antagonist because Lupron is not good for a person that has endometriosis. So they didn't want to stick me on that. You then have to do the trigger shot. And this is the same trigger shot that you used for the IUIs. It's the same one. And then so for these, every last one I had to get through a specialty pharmacy. Every single one. I had to fight tooth and nail with my insurance, and I was on edge about the timing that it wouldn't work out. The insurance argued constantly about what brand to get. I cannot tell you how many times me, my specialty pharmacy, my insurance had to call each other because they wanted to get the cheapest one. And then all of a sudden they finally decide, and the pharmacy would call me telling me, oh shoot, sorry, we're out of that brand. We don't have it, and start all over again. I eventually got everything and I had to pay very basic copays for each of these. These drugs make you very, very, very uncomfortable. The point of these drugs is to make you overproduce eggs versus your normal 1 egg. Therefore, as time goes on, you become extremely bloated. And some women, especially those with diseases like PCOS, can make anywhere from 20 to 30. I even heard a woman, I think she ended up having 62 eggs being produced. So you can imagine how uncomfortable a woman is going to feel with having her that many eggs in there. My biggest problem also is that a lot of these drugs also was causing my endometriosis to grow even farther. So it was a warning that luckily, surprisingly, my fertility specialist gave me, but we thought it was going to be worth it. So then what you could do is you can do testing before your IVF transfer. So we knew we were one and done. I wanted to make sure it was going to work. So you could do 2 different tests. One's called an ERA and one's called receptivia. ERA is measured the thickness of the uterine lining and genetic variations to assess whether or not your uterus is basically right for embryo implantation. And what it does is it determines how much progesterone you need, because progesterone is what makes you sticky. So as somebody with endometriosis, I was told to do this test because more than likely I would need more progesterone in order to make sure that that it was sticky enough for the embryo to adhere to it. Receptivia is the only test that can identify things like endometriosis, progesterone resistance, and endometriitis, which is a infection of your uterus, including markers like BCL6, which looks for inflammation of your uterus. I just wanted to make sure that I didn't still have that inflammation that we saw during the surgery to make sure it worked. These tests, not a single insurance is going to cover them. You have to pay out of pocket. They will pay for the drugs that you need, which are similar to the drugs you need for an IVF transfer, but they will not pay. I paid about $1,000 out of pocket because if we wanted to do this, we wanted to do it right. But a lot of couples can't afford that. So we did the IVF transfer. The eggs that were retrieved were monitored for maturation and then fertilized with the sperm. The embryos were then monitored until day 5-6 and then frozen or used fresh for transfer. If you want to do genetic testing, you have to do frozen transfers. Genetic testing is not covered by your insurance. Another thing I had to pay for out of pocket. I wanted to make sure that whatever embryo we implanted was a normal embryo, had no issues, because another reason they thought that maybe I was having a lot of chemical and miscarriages is because my embryos were abnormal. So we wanted to make sure. So you basically lie on your back and the doctor uses a speculum to see your cervix. They then insert a small, thin tube, like the catheter, through your vagina and your cervix. The embryos then push through the catheter into your womb. They do an ultrasound, make sure that it sticks. You wait 10 minutes, you go home, and you pray the embryo sticks. So I thought this was a cool picture to show you guys. This is my son's first baby photo. This is his embryo. So it was kind of cool. It's what's called hatching. So it was starting to split off. It was starting to do mitosis. They say hatching is good luck. It means that it's more likely to stick because it is already starting to mature to become a baby. And luckily for us, it did work, obviously. Yes. What's the question?
Let me turn off the other.
It's okay.
I apologize. I have a clap in here. So is the retrieval process painful? Even with the anesthesia that you said that they use, the twilight anesthesia?
Yeah, so the twilight anesthesia, no. And that's what's great about the twilight anesthesia is you're literally only under anesthesia for about 15 minutes. I woke up, went under, woke up, and it was done, and I was back in the room, but I was actually only out for 15 minutes at most. So that's what's kind of great about the twilight. So you don't have the same effects as what you would have from normal anesthesia. Like, I didn't have to have a tube placed down my mouth to help me breathe. Like all those kind of things didn't need to happen for it. So that's what's nice about the egg retrieval. You feel cramping and bloating, and you do have some spotting after the egg retrieval because you just had all this done up there. But by about, I think I was back at work 2 days later. So you're fine. Even my transfer, I took that day off and the next day off, and I was back at work the next day. So it's just some uncomfortableness, which mine might have been exacerbated because of my endometriosis. Anytime you're, doing a exam on me, it's more uncomfortable, but the sedation itself, no, you have no side effects like what you normally have. Twilight sedation is kind of cool that way.
Okay. And the other question was, are they able to stimulate one ovary at the same time or
you do both?
A shot of hormones?
Yep, those
so
shot
one of the ovaries is not touched even though it's stimulated and producing the mature ovules.
Say that one more time. Sorry.
So one of the ovaries is just not retrieved even though it produced both ovaries are retrieved.
Both are. Yep. So both are going to be retrieved. So they will go up into both and grab both. So for me, I had like 4 eggs in one and 2 eggs in another. So they will grab from both of those ovaries.
Thank you.
Yep. So let's see. So yes, there's embryo there. So for embryo medications, it's a bit more simpler. You're given estrogen to thicken your lining. It's injected into your stomach once a day. Oh, I forgot to say that. So the medications that you're given during the egg retrieval, all of them are injected into your stomach. You use this type of a needle. Okay, for the egg retrieval as well as for the estrogen. It's not bad. I didn't do it myself, but honestly, just because I'm like queasy, I get queasy. Like you go to do it and you stop because you're like, wait, what am I inserting into my own stomach? So my husband did it, but I'll be honest with you, a lot of women just kind of do it for themselves. They tell you to move around your stomachs that way, you don't hit a bruise or you don't hit certain places. They do teach you where to go, but it's not too bad. It's very similar to a person that has to give like an insulin injection. As a matter of fact, I think these are similar needles for that. then I get to tell you guys about this nice fun needle. So this is for progesterone. So your progesterone is taken before and for 2 weeks after transfer, twice a day. For some, you do just an injection, which goes into your butt with this needle. This needle, I'm not even kidding you, is as long as my index finger and is almost as thick as my index finger. And you have to put that into your bum. And then for some, it could be a cream that's given intravaginally, or for some, like myself, I had to do both because again, I had to make sure it was extra sticky because of my endometriosis. The cream you do by yourself, but the injections, it's almost impossible just because of also like the length of the needle, where it's going into. Some women will buy an auto injector is what it's called. So it gives you more length to be able to hit the auto injector to do it there. It's painful though. I use numbing cream, I iced it, and then I would use heat afterwards, but I still couldn't sit most of the time during those 2 weeks. You are so bruised because you're going back and forth, but because you have to do it 2 times a day, it's not like you're getting any relief because you can only go in certain areas because you're afraid of hitting a nerve. How can you use the microscopic needle? Are you talking about the larger needle, the FET needle, or the IVF injection needle to use it? The IVF, yeah. So the IVF's not bad. It's only about this big. It's extremely tiny. Again, it's like giving any kind of subcutaneous injection. So to be honest, I was pretty comfortable with it because I did it to like inject mice in research that I did years ago. It's not big. You basically just scruff your stomach and make yourself like almost like you would an animal. You scruff your stomach and you get a little bit of fat and then you just inject it into the fat and inject it. Honestly, I barely felt it. It's so tiny. It's not too bad. It's the FET injections or fat. Sorry. So progesterone that you feel. Oh, also the progesterone you're injecting is in oil. So you have to do it extremely slow. So you can't just bam and it's done. You have to do it very slowly. And also it's a lot harder to get out of the things as well. Yeah. IVF subcutaneous fat as I am. Yeah. The needle into the egg. I wish I could tell you how exactly that works. That's a question for a fertility specialist. Like they basically it was just a long catheter that had a needle connected to it that they would kind of go up into your ovaries. So it has like a needle that is large enough that it can suction, but it's connected to a catheter to help with that suction. That's as best as I know. I didn't ask too many questions. The estrogen and progesterone injections were covered. Yep. Were covered by my insurance with a copay, but I had to go through a specialty pharmacy, a compound pharmacy to get the IVF cream. Same back and forth I had to do for the egg retrieval. The progesterone cream, again, was not covered, compounding pharmacy. Super uncomfortable doing the injections for progesterone as the needle, like I said, was very large and lots of bruising. Okay. And then in 2022, my son was born. I love doing this, and I think you guys will love this too. This was our baby announcement with the embryo, and right here it says love plus science. I thought that was cute because we got to use both in order to have our kiddo. My son was born. I had an even worse pregnancy than with my daughter. I couldn't actually leave my bed for the first trimester due to pain. I had to have coverage for my job. I just didn't move. It was that painful. And not only did I have that pain, which in the second trimester went away with my daughter, I was sick throughout my entire pregnancy with my son to the point where I had to eat every 2 hours, including waking up at night, because if not, I would get physically ill because of issues with like my gallbladder and stuff. I won't go into a ton of details, but my birth story was horrific to the point where my OB, when I saw her at my 6-week appointment, said that she was retiring. And I was one of the main reasons why, because it was one of the worst C-sections ever. He had to have a C-section because he was transverse. So transverse means is that his head was up towards the top and his feet was to the side. So not quite breech. That's more up and down. He's more to the side. He's stretched out. My son actually, and they said that's actually because the endometriosis had done enough damage that he didn't have enough room in my uterus. So my son actually came 4 weeks early because he ran out of room. He, during the C-section, got stuck. The endometriosis had spread so much because of my IVF treatments in pregnancy that I had also developed what's called adenomyosis. And I had also developed adenomyosis. He got stuck on his way out. His neck got stuck in my canal because it was so inflamed from the endometriosis. For a C-section, normally you go across. Mine, they had to go up and down, and I started to feel it and started screaming during the C-section. This caused massive blood loss. I ended up having to have 3 or 4 blood transfusions during the C-section. Thank God my son was still connected to his cord, so he was still able to breathe during all of this. He came out fine. My son is beautiful. My son is perfect. And as you can see, I am still here. But my doctor also had a hard time getting my uterus back in after my son came out due to my uterus being several sizes too big. It was about 4 or 5 times inflamed. So yeah, one of the worst C-section stories my doctor, who had been doing it for 40 years, said she's ever seen. I went to St. Joe's. I love St. Joe's. I will be honest with you, if I probably did not deliver with them and did not deliver with my OB, my son or I probably would not be alive right now because it was that gruesome of a story. And all because of the endometriosis adenomyosis that nobody wanted to diagnose me with. So, oh, I'm sorry, here in Maryland. Oh yeah, lived in Maryland my whole life. Haven't gone far from here. So what is adenomyosis? This one doesn't get talked about quite as much. It's a condition where the tissue lining the uterus grows into the muscles now of the uterus. This one's not endometriosis, can't go anywhere else, but it grows into the muscle and ends up causing multiple cysts to be formed. This can also, if a lot of women who have endometriosis have adenomyosis too, and you have heavy, prolonged or painful periods, bloating, pelvic pain, infertility, similar to endometriosis. This one, though, can be diagnosed with a physical exam, pelvic ultrasound, or MRI. Mine got diagnosed as well as being diagnosed with stage 4 endometriosis during my C-section because she could see everything. But again, the only treatments are meds like birth control and pain relievers and surgery, specifically a hysterectomy. A hysterectomy is a complete treatment because once the uterus is gone, the adenomyosis is gone. So that one you can physically treat. So during 2022, 2024, after having my kid, the estrogen taken during IVF having no treatment beforehand, nothing to help me, caused my endometriosis to grow, my adenomyosis to appear. The doctor told me to just go back on progesterone birth control and deal with my symptoms. Never once was I told that an endometriosis specialist exists. I was never told that that specialist exists. I had to find that out on Facebook. I had to do my own research and found an endometriosis specialist. And I found out, luckily, that one of the most famous ones works at Mercy Hospital here in Maryland. And I was able to meet with him, and he diagnosed me with it and said, let's go. Let's do surgery. Let's fix you finally. So in January 2024, I had endometriosis removal surgery. So during this time, and you want to go to an endometriosis specialist for this, GYNs and OBs are not trained for this. He went in and did a laparoscopic surgery where he removed every last bit of my endometriosis. It was a 6-hour surgery. I also had a hysterectomy, which cured my adenomyosis. Endometriosis removal will not cure endometriosis because if any of that endometriosis exists, it will grow back. So if he missed even the littlest bit, and he can't guarantee that he didn't, it will continue to grow. After surgery, I was diagnosed with stage 4, stage 5 endometriosis, the worst it can be. It was all over my uterus and my fallopian tubes to the point where several areas of my uterus, my fallopian tubes were black. They were dead. It also completely covered my bladder, completely covered my colon. My surgeon came out, talked to us afterwards, and said, I can't believe that you have a job. I can't believe that you have children. Most women that have it that bad inside of their body have to be on disability. They don't even leave their homes due to pain. So high pain tolerance. This surgery was partially covered by my insurance. I ended up paying about $3,000 out of pocket. I had to jump through hoops to even get it done. For many states, you need to get your husband's approval before you can even have this done, especially the hysterectomy. Also won't be approved if you're too young or didn't have children. My surgeon had to do a multi-page write-up to say why this surgery needed to be done before I could even get my insurance to pay for it. For me, it was a life-changing surgery. I did not realize how much pain I was in and how tired I was because of my endometriosis. The last year has been a growth year for me where I can run around with my kids now. I don't have to take a nap in the middle of the day to even survive or sleep 10 hours, at night where I'm not even sleeping well. Like, I did not have any clue. For me, I had a total hysterectomy. So they took my uterus as well as my cervix, but left my ovaries because I am young enough. I didn't want to go into menopause. Okay, I think it's the next slide. So I'm going to warn you all. I decided I was going to put pictures from my surgery in here. They're not pretty. This is what my insides look like. P.S. The black should not be there. My friend described it as it looks like Venom from Spider-Man lives inside of me. So all of this black is actually the endometriosis that had spread and started to kill off things like, I'm not a surgeon. I can't tell you exactly what this is, but from what I gathered, this is around my bladder. This is around my colon. If I hadn't gotten surgery right then, I probably would have had to have my colon eventually removed and had a bag instead. That is how bad it was inside of me. This is only 3 out of about 20 pictures. It doesn't even show you my uterus, which had over 100 cysts covering it and weighed, what did he say? 13 pounds. Your uterus is not supposed to weigh that much without a child. So yeah. Yes, thank you. If you have university insurance and then being a Catholic, okay, what? Okay, no. So I do not, Amy, I'll talk to you about that. Talk about it later, but yeah. So I don't have our school's insurance. I go through Steve's. Yeah, I have Care First. But I will say, being at a Catholic university, and maybe it was just my department, they were so supportive of my IVF journey. I had to take so many days off to go for monitoring because you have to go almost every day for monitoring. And I was driving up to Delaware. They were fine with it. They helped me get coverage. Our dean was super supportive of it when she found out, like very, very supportive. I think because we're so Catholics, yay, children. I mean, even when I found out I was pregnant with my first kid, they gave me my contract. I signed it, said thanks. And then the next day told them I needed to go on maternity leave. So, so before or after birth? Yeah. So before birth, no. Because I wasn't 100%, I was getting the C-section, but they didn't give me anything before. After, yes, I had to go on very high pain meds. They had to give me iron because of all the blood lost. After that, no medications were given to me besides the normal pain meds that are given to a woman with C-section, which, that's a whole other story about how they over/under medicate women that had C-sections. But yeah. And then the final end to my story is, this is our Valentine's Day photo. So this is me and my husband, my daughter Violet, and our IVF beautiful baby Wyatt. So I will stop sharing now in case people want to ask more questions. Sorry, good time. There we go. Yes, a very happy Valentine. Thank you very much. Thank you very much for, having to go through it. It's better now. But like I said, for 20 years, having no diagnoses it's not great. So any questions that you guys have about endometriosis, adenomyosis, infertility, anything like that, now that it's done. Thank you. I'm glad. Please spread this. That's the reason when Dr. Hall messaged me saying, can you do this? I was like, yes, I want more people to know what this is like, and to have it be some people in the medical field that will learn about this when you might not have known what happens is even better. I really hope that more people coming into the medical field in any way know more about this when it comes to women's health, and especially infertility. 1 in 8 women go through fertility treatments. 1 in 8. So it's a lot more than I think people realize. I could have. So I could have become diagnosed before becoming pregnant. But here's the problem. Nobody told me how to get diagnosed. So the diagnoses could have came by doing the endometriosis excision surgery beforehand. So some women that have problems with infertility, they go to endometriosis excision specialists and have that removal done to help get pregnant. But the problem was none of my OBs or GYNs even confirmed that I had endometriosis or told me that endometriosis specialists or the surgery existed. So could I? Yes, but nobody told me I could. And then, so what is the number one cause? There is no cause for endometriosis that they know. Yeah, who knows? When I was looking this up, because I was like, let me just do a little bit of my own research. They love to say it's lifestyle or genetics, which is just for most diseases, that's just them saying, we don't know. They have no clue what causes endometriosis. They don't know if it's genetic. They don't know if, again, it is something in my lifestyle, but there is absolutely no or very, very, very little research that's being done out there in research labs for endometriosis, both for treatments, diagnosis, or cause. And that is the case for most women's health things. If it is a health thing that only is for women, the money that is given towards research is abysmal. Did you Google to find the specialist? Yes. So first I tried Google, which scary. But then again, Facebook to the rescue, there is a group, they're called the Nook. And this group has done extensive research into finding what are the good endometriosis specialists. So I joined this group, looked up their information, found that the one near me, found that it was covered by my insurance, that he was one of the best rated. I then did what I always did, and I went to the Hive and asked if other people had gone, which now have gone to Dr. Odlin is his name. I now recommend him to everybody. He was the most receptive doctor I have ever met in my entire life when it came to women's health. And it was super surprising because he was male. I have to admit, it was very surprising because he was male. But yeah, Google/Facebook helped me find it. Oh, thank you guys. Okay, so if you had to do it again, would you and why? I ask myself that question every time my son freaks out. No, no, I love my son. I swear. If I could do it differently, and this is why I'm very big on advocating and trying to tell my story as much as possible, I would have gotten help earlier, right? Like between that 13 and 32 of when I was trying to get pregnant, nobody even told me would even say I had endometriosis. So I would have advocated for myself more. Maybe I would have done more research, which having my degrees, I probably could have, but you're so tired at that point. You're just tired and you don't want to have to advocate for yourself. So I'm very focused on not only my daughter to make sure this doesn't happen to her, but honestly, if I know somebody that has a daughter, I'm in it. I am telling them, be careful of this. A painful period is not normal. Have your doctor talk to it. And if you are old enough, go see an endometriosis specialist and they'll be able to tell you. You have for future mommies going through financial burdens. So I'm assuming you mean financial burdens for infertility. It's tough, but what I found for people is that do your research. And surprisingly, secondary jobs will actually cover infertility. Not the greatest time to suggest working for these guys right now, but Amazon actually covers fertility 80% as a part-time. So if you work part-time on the weekends sorting their things, you can get 80% of infertility paid for, which a lot of people don't realize that, but look into it. There are companies that even part-time will cover fertility treatments, and that can help. If it's that you're having financial burdens trying to go to an endometriosis specialist and all that kind of stuff, I wish I had something to tell you that there aren't grants for this. There aren't things that can help us to help pay for it. And that's why so many women suffer, is because they can't afford what their insurance won't pay for. And I'm sorry that happened to you. But for infertility, do your research. A lot more companies that people don't know about. Starbucks, you can be part-time and get fertility treatment. I know that. Amazon. There was one more. I can't remember what it is. Those are just the big ones. But you can get part-time work and they'll pay for it. Oh, thank you for presidency. Oh, thanks. Cool. Yeah, vote for me. We'll make it so that funding actually goes back into the NIH. Do you think the liberal use of contraceptives can promote it? Okay, so this is something. So somebody asked, the liberal use of contraceptives, can it promote endometriosis? This is actually something I've been doing my own research into. My background is in microbiology and immunology. That's what my PhD is in. So I'm definitely one of those people that has no problem reading a peer-reviewed journal and understanding what it says, right? So some people believe, yes, some people believe that the overuse, especially of estrogen-based, can maybe have a link to endometriosis, just because, again, estrogen feeds endometriosis. So even if you have this little bit and you go on estrogen-based, it can just crazy spread. So I don't think that the overuse of contraceptives like birth control is causing endometriosis. We're not sure what that is, but I do think it might be causing some of the spread because too many doctors go immediately to putting you on estrogen-based birth control, which most of them are. Progesterone-based is only in pill form, to my knowledge. I don't think it's any of the shots. It's none of the easy stuff, right? You know, we all, as women, we forget the pills, so we don't like the pills. Can't find progesterone shots. I looked. So that's part of the problem with it too. Thank you guys so much. Thank you for the person who said that they did IVF after 3 years. It's a journey and it's it's a group, right? We're all super supportive of each other. And I like telling my story, and I'm lucky. I know I'm lucky. I was just listening to a thing the other day that said there's only a 20% chance that your first time doing an IVF transfer will work. Only 20%. And we lucked out that we had our son on the first try. And I realized that is a very low number. Our numbers were low to begin with. I got 6 eggs and only 3 embryos out of it, which is very low. And only one of those embryos was normal. And that was my son. So yeah, our odds were, miracle is what we like to call my son. We say it all the time. Yeah, progesterone is definitely less forgiving. Estrogen base, you have more leeway for forgetting. Yeah, agreed. Progesterone is like on it. You have to, like, I had to set an alarm to make sure that I was taking it. Does PCO? Okay, so PCOS and endometriosis. Amy, am I allowed to go over? I feel bad that if I'm taking my time. Okay, so
I'd much rather hear from you than me.
Okay,
sure.
Well, you guys have me till 3:30 when I have to go pick up my daughter from school, so that's cool with me. I love talking about this, in case you can't tell. So they have come to find that endometriosis, they believe, may be a autoimmune disorder of some kind. They think, right? From the little research that we've done, this could be an autoimmune disorder. It makes sense. It's your body almost attacking your body. And they have found that 60%, I was just reading, about 60% of people that have endometriosis also has PCOS. So there has got to be some kind of a link, either genetically, lifestyle, autoimmune disorder, whatever, linked between the two of them, because so many of them have it. And then, of course, there's also that link of PCOS with infertility. That's a huge link between the two, but they do believe there's this link. But again, the research out there is few and far between. So it's not like a lot of us know. Name of the Facebook groups. Sure. So which Facebook group? Okay. So the Nook, N-O-O-K, endometriosis is the name of the one that is run by Nancy's her name. That's the one that has all of the research on endometriosis specialists. The amount of files that she has in that Facebook group and has on her website is incredible. It's incredible. It's where I got all of my research done. It's how I found my specialist. But then there are also just support groups. So if you just look for endometriosis support groups, there's at least 2 good ones that I'm a part of on Facebook. There are tons of IVF support groups on Facebook. I'm very much a supporter. I like to be supported and like to support. So I joined a lot of these support groups. But the Nook, N-O-O-K, is the endometriosis one. And they have a website too. If you're not on Facebook, you can just go on the website. Oh, thank you guys. You guys are so nice. I'm getting all these comments and direct messages saying how much you guys enjoyed this. Thank you. You know, being a teacher maybe kind of helped too, but yeah. So lifestyle risks. So what I've read is it's food. There is more endometriosis, just like a lot of different things, allergies, autoimmune disorders. There's a lot more found in countries like ours versus like third world countries. So they believe it might have something to do with like food and the overprocessing of the food we do, the food that we eat. I truly believe that definitely could be part of it with the lifestyle. Some women have found that if you go on certain food diets, it's better for you. And for endometriosis, it tends to be a low carb, high protein diet, which is actually good for fertility as well. They actually put me on a low carb, high protein diet for when I was doing my fertility treatments to help with that as well, because it helps with egg health. So there could be that link. My endometriosis specialist definitely seems to think so. And so now I am on a similar diet to that, which is not fun. I love carbs. The pain definitely went down for me when I lost weight. So when I was in grad school, I gained a lot of weight from stress and decided to start eating healthier and losing weight. And it definitely seemed like my symptoms were a bit better. So those things probably are definitely tied to it, is just like weight, as well as I really think it's more diet that it's tied to. Because again, we don't see these in third world countries. And I would love to tell you that's not because it's underdiagnosed, but with endometriosis, who knows? But it definitely could be a lifestyle thing. No, I am not a pharmacist. Go me, Dr. Hall. Yeah. No, I just know a lot about this subject. No, my background's in microbiology and immunology. So I think it connects a lot. I just know it more on that side versus, as you guys can see, I couldn't even pronounce some of the drugs. But I will say I have a pharmacist friend that I sent this to and went, does this sound good? So, I had a pharmacist look at it. But no, I just teach fundamentals of biology over in the undergrad. So if you guys ever want to come just chat with me more, if you guys are on campus and live in Maryland and you want to come chat with me, I would love that. I'm just in Knott Hall. You can find me on the NDMU website. Apart from painful menstruation was the key symptoms that will ring the bell, endometriosis. Okay. So it's not just the painful menstruation, right? Pain during intercourse, both during and after, that is a huge ring the bell for endometriosis. Pain within not just your uterine size, but within your back area is a sign most of the time that it is starting to spread. So that is really like, that was huge for me. Having stomach issues, surprising, is a really big bell ringer when it comes to endometriosis. And it doesn't necessarily have to be a person has had it spread to that area. So again, this is why I think that food plays a very big part in endometriosis and all that. But basically, it's painful intercourse and it's the painful periods that is like, if you have either of those or both of those, just go talk to your GYN, see if they'll listen to you. And if not, just go see an endometriosis specialist. If you are anywhere near a bigger city, you will probably be able to find a specialist. Just again, that Nook website, make sure that it's a good one. Like with any specialist, there are bad specialists and there are good specialists. So go on the Nook website and they've all been vetted and are great specialists. But if you're here in Maryland, Dr. Odlin at Mercy is amazing. What meds did you use for those severe pains? Yeah. Cannabis. So the cannabis products, yes, a lot of women do end up using that. Here's the problem though, like for some jobs, of course you can't, if you do drug testing and stuff like that. I never tried that. That's just my personal preference when it comes to that kind of stuff. For me, honestly, I was just trying to take high dose NSAIDs, which is not great. I'm pretty sure I destroyed part of my liver taking some of those for as long as I did. So NSAIDs are just the thing that most of us take, and whatever, because you want to be careful with taking too high dose of pain meds due to, abuse and all that kind of stuff. But cannabis is a great thing. I would say a good chunk of the people that are in the endometriosis specialist group that are the endometriosis group that I'm in do use the cannabis products to try and help with that. And it also helps with the fact that a lot of us end up developing a lot of anxiety from all of this. So I think that helps kind of level that out as well. But yeah, honestly, just NSAIDs was kind of what I used. And then just pushing through. Again, I'm pretty sure I'm one of those women that has a super high pain tolerance. Don't we all? Especially those of us who gave birth. Any other questions that you guys have? I'm excited to be happy to answer any others. Great. Okay. Again, if you guys have any questions, Dr. Hall can give you my email, or if you are on campus and just want to shoot on over there to my office and talk to me about any of these subjects, I am an open book and love to talk about it. 13-year-old. Yeah. Okay. So if you have a 13-year-old that you think has endometriosis or has been diagnosed with endometriosis, go see an endometriosis specialist now. Even at 13, they can have the endometriosis excision surgery. The excision surgery is not as bad as a recovery as mine was. And that was just because I also had the hysterectomy at the same time. The hysterectomy is a much more intense recovery, just because I lost an entire organ. The actual excision is much easier. It's only about a week recovery. I'm not saying that that's what your daughter needs, but if you go to Dr. Odlin, he won't just, or whatever endometriosis specialist that's near you, he won't just throw your daughter on birth control. He will help to actually keep the endometriosis under control, monitor, do surgery if needed. If surgery isn't needed, other ways to maintain it. And the good thing is he is so well trained, everything can be done laparoscopically. The reason why I tell people not to go to general GYN is because, for example, in my case, if a general GYN went in there and saw as bad as my endometriosis was, they would have cut me completely open and had to do an open surgery, which is way more recovery time. He was able to do my entire thing laparoscopically. So a good endometriosis specialist will not just throw you on birth control. They will help you with the 13-year-old with figuring out a good way to treat it without over treating it, I guess you could say, with the estrogen, but also decide whether or not surgery or other things are needed. But unfortunately, the only treatment right now is to have that endometriosis surgery. And again, it's not a treatment. It could easily grow back. So she could end up having 5, 6, 7 surgeries, unfortunately. But if they do it well, they'll get it all or enough that it won't grow back super fast. But I'm sorry if you have to go through that. It's a worry that I have for my 5-year-old daughter. So I'm sorry for her. Anything else for you guys? Wait a minute. See if anybody's typed something in the chat. If not, all right. Okay.
Thank you so much, Dr. French. I really appreciate you sharing with us. It brought tears to my eyes, all the stuff that you had to go through.
I was putting together this lecture and I have never like put it all in one thing, right? Like seen it. And I was telling my friend, I either started crying when I was putting it together or got really, really angry when I thought about all of the things that the doctors have told me about, what I can just go do
Mhm.
instead. So, yeah.
I felt all those similar emotions.
Yeah.
So,
All right.
you.
Thank you guys so much and have a great rest of your class.
Thank you.
Thank you very much, guys.
Thank you.
All right. Let's take a 5-minute break. So at 3:18, and then we'll get started. All right. I have 318. I have a couple things that I want to go through. Luckily, I think some of the stuff maybe Dr. Park covered, and some of this, and Dr. French did a really great job talking about the drugs today. I'm really impressed by her ability to talk about the drugs, and hitting some of the key things that I would want you to know about the drugs. So we're going to move kind of fast here. The book chapters that correlate with this topic are chapter 11 and chapter 12, and the objectives are there for your use. So when we're thinking about becoming pregnant, or a lot of times, I guess when we're planning on getting pregnant, when we have the ability to do that, we need to think about preconception care. Sometimes we don't have the opportunity to do that because remember, 50% of the pregnancies in the US are unplanned, but when we do have planned pregnancies, we need to think about preconception care. And so one of the things that was always taught to me is that like if a person is of childbearing ages, they need to be on birth control. And if they're not on birth control, they need to be on prenatal vitamins. Because if you're not doing anything to prevent pregnancy, you better be prepared to become pregnant. So thinking about preconception care, we want to think about everybody who could become pregnant is getting preconception care. So whether that is birth control to prevent pregnancies, whether that is prenatal vitamins to help support a pregnancy should a person become pregnant, we want to be able to improve the health of a person who could become pregnant. Preconception care includes many things that we need to consider for the patient who is trying to become pregnant. We want to think about nutrition, what they're eating, how they're eating. There are different foods that should not be eaten during pregnancy. We want to think about medication use if they're on medicine for seizure disorder or high blood pressure or mental health. We want to make sure that they're on a medication that is safer to use during pregnancy. We would like to try to get those changes before a person becomes pregnant. We want to make sure that their vaccinations are up to date to ensure that they do not get tetanus or the flu, because pregnant patients are more susceptible to severe flu. So making sure they're getting their annual flu vaccine. And then talk about family planning. So whether that be preventing pregnancy or how to become pregnant. So nutrition is really important for a patient prior to pregnancy and during pregnancy. This is especially important for the fetus and the fetal development to help minimize birth defects. In general, we want to avoid herbal supplements, especially if a patient is pregnant or could become pregnant. And there are some herbals that we really do want to avoid because of the risk to the pregnancy. So blue or black cohosh, dong quai, golden seal, and feverfew can all have very bad effects on the fetus. So when we're talking to patients and they're buying the over-the-counter nutritional supplements, we want to make sure that we're advising them appropriately. We want to make sure that patients who could become pregnant or are pregnant are getting adequate folic acid. Folic acid helps prevent neural tube defects, so things like spina bifida and encephalopathy. So we recommend that the patients take 0.4 milligrams or 400 milligrams of folic acid per day. If a patient is high risk, we have them take more, or if they're on a anti-seizure medicine, we also have them take more. And we try to have them start supplementing the folic acid at least 1 month before conception to make sure that those folic acid stores are built up. Iron is something that we need in pregnancy. As soon as that sperm fertilizes that egg, we have a 30% increase in our blood volume. The way we produce blood is through iron. don't remember, because I'll talk to you about that in the fall for renal, but iron is the building blocks for red blood cells. And so we need to have enough iron. Because we are producing 30% more blood when we're pregnant, we go through our iron stores pretty rapidly. And so we need to make sure that patients who are pregnant or could become pregnant have adequate iron stores to support that increase in blood volume. Calcium is important for the bone health of the fetus and the mother. So the calcium is going to go straight to the fetus. So we need to make sure that there's enough for the mother. I had a friend who's very active person who was newly pregnant and felt very active, very strong, fell skiing and broke her femur. And that was because she didn't know she was pregnant and she wasn't getting enough calcium, and the baby was taking all the calcium. So she ended up having, kind of a weakened bone, not necessarily osteoporosis situation going on, but weakened bones from being pregnant. So we need to make sure that they're getting adequate calcium. For most people, as long as they're eating foods that are high in calcium, so they're eating dairy products, things like that, they can typically have enough calcium, but sometimes we do need to supplement. Another important component is essential fatty acids. These typically come from our fish foods, seafoods, but we have to be careful with fish because fish can also be high in mercury, which can be very damaging to the fetus. So we want to pick low mercury fish like shrimp, canned light tuna, salmon, and catfish. You may have also seen that many of the prenatal vitamins now come with two parts. They come with a tablet that is the vitamins, and they come with a capsule that has these omega essential fatty acids. Or sometimes they are in the actual capsule with the vitamins. And the ones I took were separate. There was a pill and a capsule that I had to take, and the capsule had extra essential fatty acids to make sure that the brain development of my fetus was going well as it could. We have to think about substance use for patients who could become pregnant. Caffeine being, one of the most, legal, important drugs of our lives, especially maybe in pharmacy school. I guarantee there's a bunch of you that can't function without your coffee or your energy drinks. My wild cherry Pepsi is the only thing that gives me joy every single day without fail. So we need to make sure that we're having not too much caffeine intake. The recommendation is 200 milligrams per day. My OB actually recommended 100 milligrams per day. And luckily that 12-ounce can of wild cherry Pepsi came in at like 60 some grams. So I was good there and I could enjoy that. But that's essentially 1 cup of coffee per day. Smoking, it's best that we have somebody try to stop smoking before they become pregnant, because smoking has a lot of risks for the pregnant patient and for the fetus. It can delay healing in the pregnant patient after they deliver. It can lead to the fetus being miscarried or abnormalities, decreased birth weight, premature birth, and fetal death. It also can, because when you are smoking, you are damaging the tissue, you can have infertility and difficulty conceiving, because it's not just damaging your lungs, it's damaging all kinds of vessels and all kinds of tissues all over your body. We want to recommend that patients avoid alcohol, because consuming alcohol, even in small amounts, can affect fertility. And there's been no safe amount found to be had during pregnancy. So if you're drinking alcohol during pregnancy, it can lead to miscarriage, preterm delivery, stillbirth, and the most serious, if the baby survives, is fetal alcohol syndrome, where the baby will have neurological defects, have mental health or mental challenges as they grow. And then illicit drugs, we want to avoid for the various reasons. So assessing the patient's preconception if they do illicit drugs and helping them to stop. I think you talked a lot about these with Dr. Park when she covered pregnancy and what medications were safe in pregnancy. ACEs and ACE inhibitors and ARBs are not safe in pregnancy. They affect the development of the kidneys. Statins are typically not safe in pregnancy, but we have seen some more data on them in pregnancy patients who are high risk. But as a rule, we don't recommend statins in pregnant patients unless there's some other factor going on. Lithium, methotrexate, phenytoin, topiramate, valproic acid. We're going to have Dr. DeJaco come in and talk about these use of these drugs in pregnancy. So I'm going to leave that to her because she's the expert there. Tetracyclines, they bind to positive cations like calcium. So they'll bind to the calcium that's forming the bones and the calcium that's forming the teeth in the fetus, and that can lead to staining of the teeth. And then warfarin is X because it increases the risk of bleeding, and that can be very dangerous to a pregnant patient, and as well as NSAIDs. So when a patient is trying to become pregnant, I think I might have alluded to this in my story, and I know that Dr. French spoke about this, but you can use home ovulation kits, and that will tell you when your LH is surging and when you're going to ovulate. And then you try to have sex within 20 to 24 to 48 hours of that strip turning positive, or in Dr. French's case, you go for your IUI to have the IUI done. So again, the ovulation kits, they are strips similar to what you would pee on for a pregnancy test. So you dip them in your pee, and then you check to see if your LH is surging. If your LH is surging, that means you're going to ovulate pretty soon, and this is the most beneficial time to have sex to get pregnant. But again, ovulation kits measure LH surge. Home pregnancy tests measure HCG surge. If a patient has missed a period and they think that they might be pregnant, they can do a home pregnancy test, and these are very accurate. So a lot of times when I worked in a family health clinic, the patient would be like, my pregnancy test at home was negative. I want to come in for a blood test. Well, we're actually measuring the same thing in the blood and in the urine, and the urine tests are very accurate. And it's very rare that for what starts out as a normal pregnancy, for them to do a blood test for you. If you went into the doctor's office, they would have you do the P test, which is the same type of test that you can do at home, or urine test you can do at home. So these are very accurate, and they are used to detect the HCG. And so if there's HCG present, that means that you are likely pregnant. It's best if you do it first thing in the morning because your urine is very concentrated, so that HCG is going to be very concentrated, going to be more likely to pick up a positive test. If the test is negative, you're going to want to retest in a week if you don't get a period. But these are very accurate. So going into the infertility, and what happens, you do all the things. You take the prenatal vitamins, you are tracking your period and tracking your ovulation and doing the LH test and timing your sex to make sure that you can get pregnant. You're having sex at the most optimal time to get pregnant, and none of that is working. So that leads us into, like, maybe do we have some infertility going on? So the World Health Organization defines infertility as the disease of the reproductive system defined by the failure to achieve clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. All right. And then there is a bioethicist who says that we should maybe adjust the definition of infertility and separate it out into social or physiological limitations, because there are other reasons besides physiological that a person may not be able to become pregnant. If you are over 35, this 12 months decreases to 6 months. So if you are over 35 and you've been having unprotected sex for 6 months and you don't become pregnant, that is considered time to get an infertility workup. So let's talk about the differences between social and physiological infertility. So social infertility might cover people who are single and want to have a child without a partner. It can also cover people in the LGBTQ communities who wish to conceive, but are considered socially infertile due to their relationship status. So this could be they're homosexual, or maybe they're married to, or their partner is a trans person. Um, And so that would be social infertility is I'm single, I don't have a partner, or I am in a relationship with somebody where we cannot biologically have a child. All right. And we should consider social infertility similar to physiological infertility and try to help these patients who want to have babies, regardless of whether their infertility is due to social factors or physiological factors. So physiological infertility, there's a lot of information here on these slides. Physiological fertility is what Dr. French described happening to her. She had endometriosis, which clogged her fallopian tube and caused the fertilized egg to not want to implant into the uterus. And so that is an example of physiological. There is something going on inside her body that is preventing her from becoming pregnant. This can also be PCOS. And there's a lot of different things that can go on here that are way beyond my comprehension here. But physiological means that you physically cannot get pregnant because of something going on in your body. Social infertility is related to your partner or lack thereof not being able to have a baby together. So age is the number one determinant in fertility in women. Fertility peaks in our 20s and then begins to decline because of the ovary aging. There's hormonal changes. All right. And the risk of miscarriage increases by age. So at 25 years old, you're 10% likely to have a miscarriage, but by 45 years old, you're 90% likely to have a miscarriage. And your number of eggs that you're losing, you start losing them faster between ages 37 to 38. And so age is the number one risk factor for fertility for women. Women are only born with a certain amount of eggs, and when they're gone, they're gone. Not like men who have unlimited sperm. Other factors that can contribute to fertility would be poor nutrition, extremes of body weight, so very underweight or very overweight, stress, smoking because of the way it can damage the tissues, caffeine intake, medications, and then other medical factors. So just some data on who it affects. So 1 in 5 heterosexual women aged 15 to 49 are unable to get pregnant after 1 year. So that's about 20% of patients trying to get pregnant are unable to get pregnant after a year. And 12% of them have used fertility services. Interestingly, or uninterestingly, surprisingly, I don't know, the largest population of women seeking to become pregnant tend to be age 35 plus, white and higher income, and privately insured. As you heard from Dr. French, she did have some insurance coverage, but it was still quite expensive, $10,000 for the IVF, along with the testing that costed thousands of dollars and the medication, so copay. So it is women 35 years and older who are white, higher income, and privately insured seeking out fertility treatments. Also, there are 48% of the LGBTQ population age 18 to 35 are trying to plan families compared to 55% of non-LGBTQ people. And 40% of those LGBTQ families that are trying to grow their families are trying to use assisted reproductive means like the IUI, IVF. All right. And just looking at the UK in 2018, patients in heterosexual relationships, 90% of them were using fertility treatment, where patients in female same sex was 6.4% and single parents was 3.2%. So there is a disparity between the access to fertility treatment for people who are have social infertility. So there are three types of treatments as it relates to infertility. We have ovulation induction, we have ovulation induction with IUI, and ovulation induction with IVF. And so looking at these treatments, the ovulation with induction is the most common that we see. It's most readily available to patients because it is those drugs like Clomid, clomiphene, or letrozole. Those, as you heard Dr. French say, were very easy to access for her. She could get them at the regular pharmacy at a reasonable copay. And so what this is doing is basically telling your body it needs to ovulate. All right. And oftentimes patients will start out there. If that doesn't work, depending on why they have infertility, right? Like that was not an option for Dr. French because she had endometriosis and there were some other things going on besides the ovulation. If we're looking at IVF, we use drugs like gonadotropin releasing hormone agonists and antagonists, HCG, and progesterone, which Dr. French talked about using all of these in her treatment when she had IVF. So pulling from the NAPLEX book of what things you should know about IVF treatment or fertility treatment, because there's a lot of stuff and it's not very common and it's a little bit hard to wrap your head around. This slide is what the NAPLEX book study book highlights as the most important information as it relates to drugs with infertility. So clomiphene acts like estrogen and it increases the LH and FSH, which is going to cause ovulation. Because when we get that LH surge, we get ovulation. If we remember back to our first lecture here, right? It's an oral medication. It can cause hot flashes and there are clotting risks with it. But as Dr. French's experience says, it's usually well tolerated, easy to access. Next, we have aromatase inhibitors, the most common one being letrozole. This suppresses estrogen and then helps increase the FSH, which again is going to cause ovulation. It's oral, and it's the treatment of choice for patients who don't respond well to clomiphene, especially patients with PCOS. And it can cause hot flashes as well. Because again, it's suppressing the estrogen. So if it's suppressing the estrogen, that's going to basically tell your body, like, maybe you're going into menopause. Here's a hot flash for you. Right? And then we have gonadotropin drugs, and these act like LH, FSH, or HCG, and these cause ovulation. These are sub-Q or IM. The problem with these is that they can increase the risk of tubal or ectopic pregnancies or miscarriage. So we want to be mindful of that and make sure that the patients are counseled on that. Right. The good thing about these drugs is that they trigger ovulation. So they're going to trigger that mature egg to release. The good thing about these is sometimes they can trigger the release of multiple eggs and they increase the risk of multiple births. So is that a good thing or a bad thing? I think it depends on you as a person and your medical history and your financial situation. So they can trigger your ovulation, but if you're using any of these, you're going to be at increased risk or likelihood of having multiple births. So twins, triplets, things like that. Dr. French talked about her IUI, where they basically get a sperm sample and spin it down, make sure that only the best sperm are going in there for the fertilization of the egg. And so they deliver that sperm right into the uterine cavity when the patient is ovulating. And so it may or may not require ovulation induction. In Dr. French's case, she did do the ovulation induction. I think that if you're paying for the IUI, you want to increase the chances, have the best chances of it working. So I would imagine most patients go through ovulation induction for this. And as she said, she had most insurances require you to fail this 3 times before they'll pay for IVF. With IUI, you can get multiple pregnancies or multiples because, again, if you're doing the ovulation induction, you are increasing the risk of multiple mature eggs being released at the same time. You're putting a ton of sperm in there, so very increased risk for fraternal twins with this. Next, if the IUI fails, a lot of patients will go, or not a lot, patients will go to IVF next. And so you're going to do the ovulation induction with those drugs. You're going to retrieve those eggs from the ovaries. You're going to fertilize them in a petri dish. You're going to potentially check the embryos to make sure that they're healthy and are viable. And then they're transferred into the uterus and implanted into the uterus. So again, that genetic testing Dr. French was talking about is an out-of-pocket cost, which a lot of patients will incur because they want the best chance of becoming pregnant and the pregnancy surviving. Another thing with this is that sometimes they can implant more than one embryo. So they can implant twins in case you're like 2 embryos, not necessarily, I mean, they do become twins, but they can plant 2 to try to make sure that one sticks. A lot of different things can happen there. All right. So one of the things that was talked about was the insurance. So as you can see that most states do not require private insurers to provide infertility benefits. So the states that are gray here do not require any fertility coverage. That is most of the states. There's only 22 states that require that. And so that makes infertility treatment very inaccessible to most patients in the country, right? Because we're talking that Dr. French's friend, $150,000. I think I had heard $60,000 per IVF cycle at one time. So you're really limiting who can have access to this. And this map was updated as of September 2024. Interestingly enough, Maryland was the first state to enact an infertility mandate in 1985. So that almost predates me. So definitely predates most of you, right? And so in 1985, they required insurance companies to cover infertility. And then in 2018, Maryland required that the insurance companies cover fertility preservation for patients who are undergoing cancer treatment. So when Lindsay comes to talk to us about her cancer treatment, one of the decisions she had to make was whether to preserve her eggs for future fertility. But that requires storing them. That requires that requires retrieving them. And that can be very cost prohibitive for patients going through cancer treatment. I see some questions in the chat about confusion over how the drugs work versus suppressing estrogen versus acting as estrogen. And without reading more on this in depth, I I'm not able to articulate that this is not my area of expertise. I do not deal with this. So if you want to know more about that, how they work, even though they seem to be acting differently, I would read your chapter in the book, because this is just not an area that I'm any good at. I could get there, but it would take me some reading. All right, so and then so Maryland is super progressive in their laws, because in 2021, so in 1985, they're saying private insurance has to cover infertility. In 2018, they're saying that cancer patients' fertility has to be preserved and covered by the insurance. And in 2021, they said infertility insurance laws no longer required marriage, and the waiting period had been reduced from 2 years to 1 year. And so they defined it as either 1 year of intercourse or 3 attempts of artificial insemination failing to result in pregnancy, or infertility is associated with endometriosis, DES exposure, blocked or surgical removal of fallopian tubes, or abnormal male factors. Right. So what this is saying here, and the why this is so progressive, is that this artificial insemination, failing 3 attempts at artificial insemination, that covers our patients who have social infertility, in the whether it be because they're single or in the LGBTQ community. So this is a very progressive infertility coverage here. All right. The coverage is individual and group insurance policies that provide pregnancy-related benefits must cover the cost of three IVFs per live birth, with a lifetime maximum of $100,000. There are exceptions for religious employers, employers with less than 50 people, employers who self-insure, and it does not include the storage of sperm or oocytes. So that is something to consider, that you would have to pay for storage of that. But this pretty generous policy here. So the costs that are associated with fertility treatment, the initial testing is $1,500 to $2,500. A clomiphene cycle is, with the medication and the monitoring, is $1,000 to $4,000. IUI procedure is about $1,000, so not completely out of reach. The egg preservation, so freezing your eggs, is $75,000. An IVF cycle is $10,000 or $11,000 to $15,000, with medications costing $1,500 to $6,000. And then if you need donor eggs, that's $28,000. Did I mess something up? Or is there a joke that I'm okay? All right. So we've talked about some barriers, but the pharmacist role, think about, because we're running out of time here. I'm really sorry. But thinking about the pharmacist role, you're going to have a role in community pharmacy, helping them to get the Clomid and the Letrozole. If you're working in a specialty pharmacy, you heard Dr. French talk about how challenging it was to get, and she's a well-educated person, and she's having a hard time getting the medication. So imagine, for people who are not as well educated as her, how hard it could be working with that specialty pharmacy. Managed care, is your managed care institution going to cover it? What policies are you going to put in place for patients to have access to these drugs? Ambulatory care can be a common place for helping patients with how to give the injection, what to expect, and how to manage their side effects. And so there's advocacy here if you want to know more about advocacy and things like that. Sorry for going 2 minutes over. I appreciate your time and your participation with Dr. French and your encouragement to her. I will have the checkpoint quiz posted by tomorrow morning for you all to take. And make sure if you don't have your outline due that you turn it in for the PSA, that you turn it in by Friday. All right. If there's any questions, please let me know.
Thank you.